So when I'm approaching a new patient with a new diagnosis of mantle cell lymphoma, and if this is a younger patient who's eligible for intensive therapies, I think there are several good options to consider. The ones which are most commonly utilized would be intensive induction regimens such as the Nordic regimen, which is a maxi R-CHOP alternating with rituximab and cytarabine, 3 cycles of each, followed by consolidation with autologous stem cell transplant. The second option that's commonly used now is was developed in Europe with R-CHOP alternating with R-DHAP that incorporates high-dose Ara-C as well as cisplatin, and also is consolidated with autologous transplant. Third option that's still used fairly commonly at some centers in the U.S. would be the rituximab hyper-CVAD regimen, and that's typically given without an auto transplant in first remission. Of those 3 options, I prefer the Nordic regimen. I don't use much R-hyper-CVAD. I think it's very hard on patients over 60, and it makes it difficult to collect stem cells later. I prefer the Nordic regimen over the R-CHOP, R-DHAP because I have had difficulty getting patients through the cisplatin part, and that can burn bridges a bit later when we're looking at stem cell transplant. Regarding the use of autologous stem cell transplant in patients with mantle cell lymphoma as part of first-line therapy, I think this is a controversial question in the field right now. Some of the regimens which have produced the best progression-free survival do incorporate autologous transplant. So I think in 2016, if the goal is to produce the longest possible first remission for a younger patient with mantle cell lymphoma, I do incorporate autologous stem cell transplants. This would be typically following an induction regimen like the Nordic regimen or R-CHOP alternating with R-DHAP. But even if a patient comes to me having had a different induction, I do feel that this gives the patient the longest possible chance of a durable, and by that I mean 6, 7, 8, sometimes I have some patients 9, 10 years out in first remission. Now moving forward, in the next few years, we may be able to identify patients who do not benefit much from auto transplant using newer techniques such as minimal residual disease analysis, but currently I would say that this approach is considered investigational and is restricted. I would restrict that application to patients involved in clinical trials.